So I'm now going to turn things over to Dr. Pyatt to introduce this evening's faculty. Dr. Pyatt?
Great, thank you, Jen. We have a superb faculty tonight for our program, and I'll give you a brief description of each person. So Dan DePietro, MD, is an interventional radiologist at the University of Pennsylvania with a strong interest in undergraduate and graduate medical education. While at Penn for both medical school and residency, Dr. DePietro was involved in numerous educational endeavors, ranging from integrating radiology into the medical student curriculum to developing web-based modules to assist residents in learning chest CT. He received additional training with medical education as part of Penn's Teach Medical Education track and as a medical education fellow. Catherine Everett, MD, MBA, FACR. Catherine is a 1972 summa cum laude graduate of Duke University. She attended the University of North Carolina School of Medicine and completed residency and fellowship at the North Carolina Memorial Hospital in Chapel Hill. She is in private practice at Coastal Radiology in New Bern, North Carolina, where she has served as practice president and chief of staff of Carolina East Medical Center. Catherine obtained her MBA at the Yale School of Medicine in 2010. She has served as president of the North Carolina Radiological Society, as well as serving on the council steering committee, and she is currently on the board of chancellors of the ACR. Catherine is also treasurer of the AAWR. Her practice is part of Radiology Partners, where she serves as associate chief medical officer in practice analytics. Dan Rodgers, MD, is an MSK-trained general radiologist who serves as president of Kanawha Valley Radiologists, a small private practice group in Charleston, West Virginia. Dan is also the current president of the West Virginia Radiological Society, and he chairs the Economics Committee for the ACR Commission on General, Small, Emergency, and Rural Practice, in addition to serving on the ACR Council Steering Committee. Mary Scanlon, MD, FACR, is a clinical professor of radiology at Penn Medicine, and she is the vice chair of education. She has been program director for diagnostic radiology since 2006. 2 years running, 2022 and 2023, Penn has been named the best radiologist training program by Aunt Minnie. Her research interests center on radiology education and new ways to reach Gen Z and millennials. Mary is also the president of the APDR, and we appreciate this joint program with them this evening. The APDR, as you know, is the Association of Program Directors in Radiology. She also serves as the APDR counselor to the ACR, and she has just finished chairing a national task force on how to ensure that resident training meets the procedural needs of the population we serve. Mary is passionate about organization and political activism. She is past president of the Philadelphia Röntgen Ray Society and the Pennsylvania Radiological Society, and she was the honored radiologist by both societies. She is the current faculty liaison to the PRS RFS section. Mary was named as the 2020 ACR Advocate of the Year. She is currently a board member and treasurer for the ACR's RADPAC. It is quite an honor to have these four superb faculty this evening, and I will turn the program now over to Catherine Everett. Dr. Everett?
Okay. So I believe this statement sums up the issues we're facing. The gap between what the radiology residents and fellows are learning and what they need to know. So this analysis came from a 2022 white paper in JACR from the APDR Task Force on the lack of hour services in rural and small practices. The task force developed a framework for hour procedures based on complexity, equipment, and personnel needs. Level 1 procedures were those all radiologists should be able to perform and require no specialized personnel or equipment. And the resident and fellow data quoted here is from ongoing ACR surveys. Only 2 of the 13 procedures assigned level 1 and expected skill of all radiologists by the APDR Task Force were in the comfort zone of more than 50% of finishing fourth-year residents and fellows. And those two were paracentesis and thoracentesis. So we have a mismatch combined with the workforce shortage is likely a crisis. Come on. Can't get it to advance, guys. Just a minute. There. Okay. So part of RLI is to expose radiologists to real-world business principles. So I'm putting on my MBA hat, and I'm going to present briefly the jobs to be done theory. It was developed by Clayton Christensen, who's a professor at the Harvard Business School. McDonald's decided they wanted to assess their milkshakes, which they don't even call them milkshakes. They wanted to know if they could grow the business and how they stacked up against their presumed competitors like Burger King and Wendy's. So the first thing they did was develop a focus group with a task of improving the milkshake. So they did test tastes and packaging and rebranding, didn't change the number of milkshakes sold. Someone then pointed out they were looking at the idea incorrectly. What they really needed to know was the job of the milkshake for the customer. So the team put observers in McDonald's. They got the following data. Most milkshakes were sold before 8:45 a.m. They were solo purchases, and most were single adults. They then asked the buyer of the milkshakes what job the milkshake served and what other products were tried instead. So several people said donuts, but they were sticky on the steering wheel. Others said bagels, but putting on the cream cheese takes two hands and it's difficult to drive. Others said a Snickers bar, but didn't last very long. Others said bananas, but they were just awkward to deal with. So the result of the job is that the milkshake actually helps the drive be more pleasant. You can hold it with one hand. It's thick and long lasting. Takes 23 minutes to drink through a straw, and it lasts for hours, which counters the 10 a.m. hungries. So what's that got to do with radiology? I think we created the wrong name for the job in the 21st century. The job was named then, create a workforce of subspecialty radiologists. So how do they do that? Well, in 2014, the ABR changed the board requirements, encouraging fellowship training and with less value of a general radiologist. 95% of radiology residents do at least one subspecialty fellowship. The development of a separate specialty of IR decreased the number of procedures available to DR trainees. The IR training in procedures fell from 30%, 34% to 14%. And then presently, diagnostic radiology residents are required to perform only 25 image-guided biopsies or procedures. So we got the wrong job. If you look at AAWR job postings, just like ACR, 41% contain the word general radiologist for job description. Data from the HPI, top 25-hour procedures by volume comprise 75% of the billing, and 85% of these are not performed by IR. 55% of subspecial radiologists perform less than 50% of their work within the subspecialty. And which is a concern of many of us, the performance of light IR by NPRPs has grown exponentially from 0% in 1994 to 11% in 2012. The generalists are retiring, and when large systems and practices acquire small hospitals and practices, then there is a great need for versatile radiologists to cover these practices. So what is the job? In my opinion, is to create a workforce of radiologists with subspecialty expertise.
Thanks, Catherine. I'll now take over the presentation here and talk a little bit about what we have done in response to those problems. Okay. So there are 5 steps in the change management process that we're discussing here this evening. The first step is preparing the organization for change and identifying the problem, which Dr. Everett started to do there. But then the second step is to craft a vision and a plan for change. And so in response to identifying that mismatch between how we're training our residents currently and then the needs of the workforces and the radiology practices which will hire them, a task force was created by the Association of Program Directors in Radiology. And all of the panelists this evening served on that task force, among others, to try to take a closer look at this, to identify, what were the factors that led to this mismatch and what could we possibly do about it. So I'll be talking a little bit about the work of the task force, what we saw, and the recommendations that we've made. And then our additional panelists, Dr. Scanlon and Dr. DePietro, will talk about steps 3, 4, and 5 of what to do with those recommendations. So the task force was created to address this mismatch, as Dr. Everett explained to us. Diverse composition of the task force, including private practice and academic radiologists, program directors, interventional and diagnostic radiologists, subspecialty radiologists, and generalists such as myself. We had 10 virtual meetings over several months in 22 and 2023. And we have a final report that we're submitting to the JACR for publication. We did a fishbone cause and effect analysis after the result of our first few meetings, kind of identifying the different factors that have led into what created this mismatch. And as Dr. Everett explained, one of the number one factors was the change of the ABR examination structure back in 2014, kind of de-emphasizing general practice skills, not testing that as the final exam, allowing for some subspecialization in the final exam. We also identified some issues with the ACGME, not actually requiring certain case logs or certain minimum procedures to graduate from residency. The creation of IR as a separate specialty and a separate residency program also seemed to play into some of these factors over the last few years. The residency training curriculum, several problems there. Again, not identifying these procedures of a general radiologist as being something important that needed to be signed off on prior to the end of residency. Just the increasing subspecialization over the last 20 to 30 years, which was a good thing and a necessary thing, but which we're now living with some unintended consequences of that, where some radiologists are coming out so subspecialized, they're really not comfortable doing some of the general things that we need everyone to be able to do in our practices. We identified just the increasing volume and overutilization of studies, everybody being so busy, particularly in academic departments, and really not able to focus on training in these different areas, changing practice patterns with the rising use of non-physician providers, such as PAs and nurse practitioners who may be doing a lot of these procedures in residency programs, economic issues with a lot of these procedures being low in reimbursement and not things that people are eager to be doing. And then also we just identified some generational and cultural issues with the current generation of residents, perhaps maybe not even being exposed to these things or exposed to general radiologists and being willing to go outside their comfort zone and do these things. So all of these 9 factors we identified as leading into the mismatch. And so what did we as a task force do? Well, we came up, first of all, with, what are we even talking about here? What are the general radiologist procedures that we think that every radiology resident graduating from a program should be comfortable doing? And so we worked together and spoke with outside stakeholders to determine a list of 10 procedures, which I'll go over in a moment. And then we also came up with a few basic recommendations to different stakeholders involved in training residents. And that's the residency programs, the ABR, and the ACGME. So as far as a list of the procedures, different people had come up with different lists. This was the list that we came together. This is certainly something that all 7 radiologists in my small practice need to be able to do, regardless of their subspecialty training. In a small and rural area, we send people to staff on site at particular hospitals, and they may be the only radiologist on site on a given day. And so in order to be able to provide care close to home for patients, pretty much everyone in our practice needs to be able to do all 10 of these procedures. And so this is kind of what we as the task force felt that every radiology resident should be comfortable doing upon graduation of their residency. And so what were our recommendations as far as being able to train the residents to be able to do these things? Well, we thought that IR rotations for diagnostic residents should be reoriented to make sure that they're doing these 10 general procedures, that staffing is such that they're able to be first assist or to perform any of these themselves and to gain comfortable and to become comfortable with doing them. We also thought that there should be a general procedures rotation in the 4th year of residency, closer to the time of graduation, so that graduating residents will be familiar with doing these kinds of procedures. We thought there should be minimum procedural requirements for each of these procedures during residency, and that there should be log books and case books to document that, and that the faculty should attest to the competency of each resident in performing these things. And then finally, we created a separate task force looking at a procedural toolbox to help residency programs adequately train their residents. And Dr. DePietro will talk more about that in a moment. But those were the basic recommendations of the task force. And then now it's up to program directors like Dr. Scanlon and others to implement them. And so she's going to talk about their experiences at the University of Pennsylvania. Thank you.
Yes. Okay, very good. Let me start sharing. Do you want to continue? Yes, share screen. And this should be it. Can you all see everything, I hope? Okay, so a little overlap is good. So over the next,
Mary, we don't see your screen.
you don't see my screen? Let's see. Well, I'm going to get an F for this then. Hold on 1 second. I said share screen and share. Now you do.
Yeah.
Is that correct? All right, awesome. So a little overlap is good. So over the next 5 minutes or so, I want to review the task force recommendations, and then also through a change management lens, discuss how we're implementing it here at Penn. So again, the recommendations were to adopt the list of procedures expected of a general radiologist, to include defined minimum numbers, robust assessment, procedure-specific checklists, faculty attestation, intentional curricular design, such as exposing trainees throughout all 4 years, create as needed general procedure rotations, strongly encourage R4 electives, and the use of complementary resources like sim training. We have in our lounge a sim training center on a shoestring, and then the development of online self modules, which Dan will be talking about. So what were our recommendations to stakeholder societies? Well, to the ABR, if you don't test it, they don't value it. And so the strong recommendation was to test procedures expected of a general radiologist on both the core and certifying exam. And check indeed, the ABR is doing that, effective the current R1s right now. They will be tested on both of these exams, and we applaud that the certifying exam is now going to be a general exam, and it will be an oral exam. The other thing we did recommend was for them to add a PD procedural sign-off to the final R4 attestation. Not quite sure if they're going to do it, but we put that on the table. And then to ACGME, if you don't track it, the residents aren't going to value it. So our recommendation was to revamp procedure logs to include procedures expected of a general radiologist. And bada bing, check. The ACGME has done that, and Dan will talk about it a little bit, but it will be rolled out this spring, and it will include every single one of our lists that we have of those 10 procedures. Now, we did ask them to do minimum numbers, and that's going to take a while to do because they like to collect data for 4 to 5 years before they might even consider defining minimum numbers. And even after collecting that data, they may not actually require minimum numbers. So this is why it's so important for us as program directors at our programs to set defined minimum numbers and to enforce them, because it's going to be a while before we're going to see that, if at all, from ACGME. And then to our own societies, APDR and APDIR is really champion procedural programming and getting the word out, getting the message out to everybody. And we've been doing this. It was a topic at the inter-society meeting. We have this webinar this evening. It's going to be at the AUR. Dan is going to be doing an update and presenting, showcasing the modules. We have fingers crossed that the chief resident group will be discussing this at their annual round table. I think we might get that. And I know for a fact that at the ACR 2024 meeting, the RFS group is definitely presenting this. So we're doing it. We recommend collating best practices for general procedural access and assessment, and that will be posted on our web and rolled out. And we really want to support and create opportunities and rotations for residents' exposure to private practice models. I think that's really important, so they see that they're going to be doing this out there. Okay, so task force recommendations. Training today for the needs of tomorrow. So in my opinion, we need both generalists and the specialist. And I think we can do both with the new oral exam focus and messaging. The generalist, the fundamentals taught in residency enables graduates to provide good care in all aspects of radiology. They got to get that through their heads. And they have to understand not to let perfection get in the way of doing a good job providing necessary care. This is an access to care issue. And I must say, I'm a Kurt Shafi devotee, and those are his words. So the specialist, we need to train them to be the smartest person in the room. And we do that during their R4 concentrations, if they will, and also in their fellowships. And once again, not just read, but do, a Kurt Shafi phrase. So to all resident societies, we are recommending we need a culture change. We need to get this message out to them. They don't have to do a concentration to do a para or thora. They don't need to do a separate fellowship. What we train them in their first 3 years, and in some programs their first 4 years, is them to be a generalist, and they can do it. And this is the culture change we have to get out to our trainees. So then moving from the recommendations to our PEN plan to implement through a change management approach. Of course, there's prepare the organization for a change. And that's very important. You know, you need to bring your organization, your residency along for the journey. And this journey has been going on for a while, since we first heard about Dr. Piatt's task force, you know, that all the alphabet soup in resident education is not doing their job, and they're not meeting the procedural needs out there. So that message, you know, that brought back to the program. And then at AUR 2022, we basically, you know, did focus groups and analyzed, are we really not doing our job? And indeed, it seemed like we were not. And so that's why we created the task force. So along the way, been keeping the program up to date and informed. So it's not like a surprise that we're doing this. This last summer, what we did was we took Kurt Shafi's AUR talk, Learning to Do, Not Just to Read, and we showed it to all our residents. We showed it to all the PEC faculty to get them knowing that this is the message we need to get out. And then, you know, from 2021 on, been discussing this with the chief residents. You always got to get your chief residents on board and modifying stuff based on feedback. Discuss it at your program evaluation committees. And discuss a town hall meeting. So, you know, they feel like they've been informed, they've been along, and now we're going to do it, and it's not a surprise. An important thing to implement change is to craft a vision. And our vision here is graduating residents will be comfortable and competent in procedures expected of a general radiologist. Plan for change. What we're doing is getting baseline data, how many of these procedures did our graduating class of 2023 actually do? Collate section-specific stated policies on the number of procedure days that they might get on neuro, MSK, ultrasound, breast. Reassess our current sign-off process, review our current procedural checklists, create new forms for procedures not previously defined as our beloved PC4 procedures expected of a general radiologist, and review the current minimum numbers deemed independent. And now we have to implement the changes, announce go live date, which is now. We've rolled out the new checklist with the minimums. This is effective the current R1 class. According to our assessment, increase or not the number of procedure days on ultrasound, CT, MSK, and neuro. Make sure the chief fellows are aware of this and schedule. And, you know, as these modules come out, and Dan will talk about that, incorporate procedural modules into rotations and offer to all our fellowships. We're also disseminating to the class of 2025 available blocks for R4 elective and procedures. And we have this resident lounge sim center. And so we're going to introduce it to the class of 2027 and moving forward, actually schedule into our R1 intro to radiology. And now finishing up with how we're going to review progress and analyze results, all part of our change management approaches. So I'm going to be reviewing the ACGME procedure log submission at each semi-annual. I'm going to be looking at the competency submissions of every trainee with them in their learning plan at our semi-annuals. I'm going to look at the procedural competency submitted in 4-year aggregates and the % of our residents who are achieving the new expectations. Review the number of expected procedural days to what is scheduled. Review the number of folks doing the R4 procedural electives. Review the number of fellows doing those procedural modules, and feedbacks from semi-annuals, rotation evaluations, and then actually do a graduate survey on how residents are feeling leaving the program. Are they feeling competent and comfortable in doing these procedures? So I think that's all for me, and we're going to let Dan take this over next. And so let me move this and let me stop sharing. Can you see, have I stopped sharing it? No. New share, stop share, I found it.
All right, thank you, Mary. Looks like everyone can see my slides here. So I'll be wrapping us up with going over kind of these 2 steps of those 5 steps in the change management process. So implementing the changes, that'll be the modules from our procedural toolbox I'll be talking about, as well as reviewing progress and analyzing results, which we'll discuss some of what we've done with the ACGME to help programs kind of keep track of all this. So, you know, that task force identified this year as kind of one of their priorities, improving educational resources available to residents regarding these 10 procedures that they decide were the procedures expected of a general radiologist. So, you know, what is the best way that we can improve those educational resources available? Programs can do some things, but there are other resources that can be made available to trainees and, you know, even graduate physicians more on the national level. You know, we didn't want to just wing this using educational theory and papers that are out there. You know, there are evidence-based ways to teach procedures. This is one method here, kind of a 6-step approach: learn, see, practice, prove, do, and maintain. It's a model of procedural training. So, you know, from my standpoint, from the toolbox, procedural toolbox task force standpoint, these are the 2 that we can really address. We could help residents see how to do these procedures and learn how to do them. But it's really on programs to focus, you know, more on the remaining in-person and hands-on components. But by kind of offloading programs, some of these first 2 steps here, we allow them to focus on these last 4, and then provide a nice kind of way for residents to learn these procedures before they get in there and start doing them. So again, we are planning, you know, modules basically for each one of the 10 procedures that was, you know, decided as a procedure expected of a general radiologist. And these modules have 8 or so sections, always the goals and objectives, showing them how to do a pre-procedure assessment, some core principles of the procedure, consent, the equipment and setup needed, the procedural technique, post-procedural eval, along with some example cases and pre and post-assessment questions. Big parts of this are to not make it like a textbook. We really want to have a lot of multimedia in there, as well as ways for folks to self-assess themselves as they go through. Because, there's a lot of resources out there already in terms of PDFs, papers, and textbooks, but oftentimes it's better to have pictures and videos to kind of show you how this all works. So this is an example of the breast biopsy one that we had a pen is now being kind of converted into the APDR module, where we have a lot of pictures showing you the biopsy devices, how to plan your approach, some check your knowledge questions throughout, as you can see here. Big pictures of just even how to set up your room and how to set up your table to do this procedure. So you can learn all this before you even walk into a room on your first day on your breast rotation where you might be assigned to do procedures, and have all this knowledge in hand, and then go and ask the questions that were left over from the module and just be ready to get started. Additionally, if you haven't done a biopsy in a few months, you can refer back to this and remind yourself, say, how those biopsy devices worked. Here included are a few videos showing you how each common biopsy device works and going through that over a few minutes for you. So some great reminders and just great intros to how this all should be working. And these modules will be available for each of those 10 procedures. They're created using REDCap, which is more of a research and survey tool, which we've kind of hijacked because it can include a lot of multimedia. It can include questions and text easily, and they'll be available basically open source via simple website links. To be determined where they will be hosted when they're done, but it will be on a national website available to all programs for free. They will be available by academic year 2024 officially, but really, the goal is AUR 2024. And while we're using REDCap now, our goal is to get a grant in to help improve website design and host them on more of an official kind of website rather than these REDCap modules. But it's a great system for now. Moving on to kind of reviewing progress, analyzing results, I'll briefly go over what Mary, ourselves, and the ACGME has done to kind of help keep track of what we do. So the ACGME case log is has been used by interventional as well as diagnostic residents for a few years now. It came into fruition kind of when I had started as an interventional resident about 5-6 years ago. This says how you find it. So here's the case log system. There were a few issues with the case log system, being this was the first time radiology was really using it. But the goal for us is that you need to be able to keep track of these 10 procedures for both diagnostic and integrated interventional residents. So this is pretty easy for a procedure like a paracentesis. There's only one code. You type in para, and it brings you to paracentesis. You click it, and that counts as one. The issue comes with some of the other procedures. So in the current and what will soon be considered the old system, not all procedures had a tracked code. Here I show all the biopsy codes that are in there, but one that's missing is breast biopsy. So we had no real good way of keeping track of the number of breast biopsies you had done within this ACGME system. Other things that did not have an assigned code that was easily trackable were lumbar puncture and many of the MSK aspirations and injections. Additionally, in the current, soon-to-be old system, some procedures had many different applicable entries. So here I'm showing the different types of drainage procedures you can enter, and there are numerous types of drainages you can do. You can have a mediastinal tube, a retroperitoneal tube, and many others. The problem is you couldn't query this in any way. You'd have to do each one individually and add them up to determine how many drainage procedures you've done. So there's no easy way to kind of keep track of some of those 10 procedures where there are multiple different ways to enter them. So with the ACGME, we are updating it to have these new track codes available to make sure all 10 procedures expected of a general radiologist are captured. And then we have introduced some new ways to kind of query the data so that if you can now click a button, I'll say, give me all the numbers of image-guided abscess drains for this resident over their number of years as a resident, and it will pull in all those different types of abscess drains or different types of biopsies and spit out that one number for you. So now we can much more easily keep track and kind of assess how folks are doing. So that's all I've got from my standpoint. I think now we're going to open it up for some questions. I'll stop sharing the screen here.
Second. Share my screen. Okay. All right. So thank you to our faculty for just some really great, amazing, informative talks on this topic. So we're now going to move on to the Q&A component. So just to refresh everybody's memory, if you want to ask a question, go ahead and click on that Q&A icon on the Zoom control panel, type in your question, and then we'll see it on our end to be able to ask it for you. So we do have a few questions that I'm going to go ahead and ask. And the first one is for Dr. Scanlon. How do I create a task force?
Okay, well, I had no idea how to do this. And so I actually Googled it, how to create a task force. And so I learned it that way. And I think the most important thing is really to start with a charter for your task force, where you have the problem statement, you have your mission, you have the scope of what you're doing, a mantra. Our mantra was maybe minor procedures to us, but not to our patients, and to list outcomes and deliverables, a timeline, and markers of success. And that's what we did right up front. And then one thing we did, I think, that really helped move the whole task force along, was a modified design thinking approach, where basically ask the question, everybody on the task force, think, what are your top 5 reasons why you think we got to this point? And so everybody on the task force did that. And that's how we then collated all of that and put it into those buckets that Dan showed you on that fishbone analysis. So that's how we did it.
Perfect. Any other comments? Okay, next question. This is for Dr. DePietro. So regarding the modules and toolkits in development, what's involved in incorporating these? Is there a fee? Is there more than one to choose from? And if yes, what are the main differences? So I guess to start off with, so what's involved in incorporating these?
So, I mean, it should be pretty easy for residencies to incorporate them. Once, we do have them hosted on a website, there'll be 10 links, paracentesis module, thoracentesis module. Those links are available to basically anyone who were to go to that website. So we're trying to keep it nice, simple, and easy for folks, and really just trying to make it easier. Right now, a lot of residents, they may read something on how to do a procedure and then go look on YouTube to see how it's done. And those videos aren't great. There's not great multimedia resources out there. So this kind of puts it all in one spot for them to make it super accessible, super easy for them to learn how to do these. Residencies will be more than welcome to copy those links into kind of their meta guides and whatever they hand out to residents when they start rotations. And that's what we'll be encouraging, so that they know they're right there. They could get them done, as they start a rotation before their procedural days, to either learn or remind themselves how to do certain procedures. Certainly no fees involved. REDCap is free for us, which is why we're using it. And hopefully, we'll get a little funding to get a official APDR website going or something like that for it. But the REDCap modules will be, they could go for years without, needing to be on a different platform, and we're just going to update them as needed.
Perfect. And then there was another component to the question: is there more than one to choose from?
Yeah,
and if so, what are the differences?
The only difference is, they'll be dedicated to each type of procedure. So, there'll be 10 of them, one associated to each of those 10 procedures we talked about. Image guided biopsy will in and of itself include ultrasound and CT guided biopsy. So that one's a little unique in that sense. The venous access one will include a bit more as well. So some are more involved than others, whereas, paracentesis and thoracentesis are a little more straightforward. But, other than that, they're consistent in format. We've set them up so people could recognize them as what they are. So we'll be consistent in that way, so everyone kind of knows what they're dealing with.
Perfect. So our next question is, there was early mention of NPRPs performing many of these procedures in the academic departments. Are they the professors teaching them to residents? If so, how do the residents respond? Does anyone have any experience with this?
I don't have a lot of personal experience with that myself, but I mean, my understanding is that these are kind of more basic procedures compared to advanced vascular or IR procedures, and so my understanding is that a lot of departments and programs are just kind of offloading all these things to mid-levels to be done. And so I think that's one of the reasons why residents aren't getting trained. From what I know, I don't think the mid-levels are training the residents. I would defer to Dr. Scanlon and others in academic departments to talk about that. But from my own perspective, I think, residents should be trained by whoever knows how to do these. It wouldn't matter to me personally whether it's an attending physician or a mid-level, as long as the residents are graduating with the appropriate skills.
So, I mean, we have no issues with an NP training our residents. I think there's some oversight things, but I know we're hiring someone or have hired somebody for one of our for Pennsylvania Hospital, and that person's gonna be doing some of these procedures, and I'm all for the residents getting in there and also learning from them as well. Dan, what do you think?
Yeah, from our perspective, there are PAs and NPs doing a lot of these, but we still do a fair amount of them ourselves, given there's enough to go around. We prefer to teach the resident ourselves and do that. We actually don't let the NPs and PAs teach and observe the residents in that sense. So we keep all of the training, attending, and resident on things like paras and thoras. Technically, at least in Pennsylvania, PA and NP is not supposed to be in charge of a resident doing that. So one of us would have to be there anyway. So we let the PA and NP go to something else, and we teach the procedure to the residents. So I think it's nice in that sense because we have kept this, attending and resident education intact throughout all these procedures. Depending on how things go, some lines might have to be blurred a bit and adjustments made, but that's how we do it for now.
Any other comments?
So one of the thing is that Mary mentioned was to change the focus or change the idea of the residents themselves going in a different direction, learning these procedures. One program director I know said that he actually hired NPRPs to do basic procedures because his program got dinged by the residents because they said they were doing too many of these procedures and weren't spending enough time, reading studies. So I think that's another part of change is changing the culture of, we're radiologists first and we got to do basic radiology before we turn into the super specialist.
Any other comments? Okay, next question. What types of changes do program directors need to plan on making? What do you think they should be thinking about at this point in time?
Very good question. I think they've been, and it also varies a lot with the programs because there's some programs that don't have a lot of fellows that have more procedural experience than others. I know Brent Griffiths is on here, and his program, his residents have a lot of experience, and then some other programs they don't have as much. So like for us at Penn, we have to really up our game in terms of getting this experience for our residents, which we're definitely doing for all 4 years. So it really depends on where the program has to do their own self-analysis and see where they currently are and then change or modify accordingly.
And I would say one thing programs need to, it's tough, but need to do is really show residents the relevance of all of this, because some folks, they're training in an academic center or, even a mixed academic type institution, and they think they're going to go be a neuroradiologist and that's it. So I don't care about MSK arthrograms. But if you can show them that each of these procedures, it's all needle placement using imaging guidance. If you are good at abscess drainage, at PICC lines, at MSK arthrograms, you're going to be the best at LPs because you know how to put that needle somewhere small using imaging guidance. It's all the same tools. So reminding them, like, that's just one way to remind them of the relevance when they think it's not relevant to what they want to do. I think it's also hard for them to see that, they may go into a practice where they're practicing different than what they did in residency, and reminding them it's relevant for that as well. So programs do need to do a better job of just reminding residents, because that's what residents need now, is they need to understand the relevance. And that's, I think, tough sometimes for them. And our job as people who are in program leadership.
And so, Dan, just like you were saying before, these modules are so important for our current resident training, but it's also wonderful for people who are out in practice. And for our military radiologists, they were all excited about this. I heard. And so really just yesterday, I was talking to one of our former graduates who was in private practice in North Carolina, and she is a neuroradiologist, right? That's what she did her fellowship in. And she just told me that she's doing like 30% breast. And including some breast biopsies, and you can do it, and having these modules available is a quick refresher course to make people feel more comfortable. And one thing, Dan, that we didn't bring up, and I'm really hoping phase 2 of all this is that we will be able to do go to a next phase of doing virtual reality with these modules. So when you're doing it, you can actually envision yourself and you're in the room making those choices of what needle to use. And I'm hoping that's going to happen over the next 2 years.
Any other comments? Okay, next question. Why would or should a residency program make this one of their opportunities for improvements?
Well, it's an access to care issue. It's important. And if they're not turning out residents who are comfortable doing with it, they need to. And so a perfect way is to make it one of your goals. I mean, ACGME asks us to always have goals for improvement for each year that we report on. And so this is an ideal one to do if it's not already in place.
Any other comments?
Yeah, and I would just add to that by saying, going back to what we talked about at the beginning of the presentation. I mean, the purpose of a residency program is to train residents for practice. And so, the biggest reason why a program should make these changes is to make sure that they're putting out graduating residents that are capable of fulfilling the jobs that we have in the marketplace. Because we've identified this gap in the training, and so to be able to train residents for the jobs that are out there, you need to make these changes.
Well,
any other comments? Any other comments? Okay, will residencies be graded on the efficacy of their adapted programs? If yes, what are the metrics?
I don't know, Dan, do you think there's any metrics defined? I mean, it would be perhaps ACGME surveys, program surveys of residents of their comfortability doing this. And then I think something that we'd love to do is start doing surveys of where practices our residents and fellows go to, and see how we're doing that way as well.
Yeah, as far as metrics, I don't think programs need to be worried about hitting their numbers yet, because it's going to take years to get all that data and figure out, like Mary was saying, ACGME may, after 5 years, not make a recommendation at all. But internally, we need to keep up those numbers so that people are getting trained. So it's kind of more on us and probably ACR, APDR type recommendations to hit. But I don't think anyone's going to get audited on any of this. But I wouldn't be too worried about that if I was folks.
Okay, any other comments? So next question is, what happens if programs do not incorporate the APDR Task Force recommendations?
Well,
anyone want to take this one?
Just like Dan said, we're not doing our job meeting what our patients need out there and what the job market is looking for.
So here's a comment from one of our participants. The ACR Career Center now requires practices listing jobs to indicate the procedures that will be expected of their new hires. And they're saying job seekers should pay attention to those lists.
Yeah, I think that's going to be really helpful in kind of helping to track what procedures are needed. I think we'll be able to get more data on that based on the postings on the ACR Career Center to know what practices are requiring from their applicants. So I think that's going to really help us as we go forward and try to, adapt and change all of this. But yeah, that's a great resource also for job seekers to kind of know what the practices want, as opposed to joining a small practice and not realizing that, we need you to do breast biopsies, even though you're a neuroradiologist. So getting that out there, up front, I think is a good thing, and making more people aware that they're, not everything is in these, neat, tidy silos, that in real life, people do a little bit of 2 or 3 or 4 things. And that's what we need in private practice to be able to get the work done and staff our small sites efficiently. And as was mentioned earlier, keep access to care close to home for our patients that may not live right next to the big academic center.
Any other comments? Okay, the next question is, what is the time frame you think it will take to successfully make and incorporate these changes? When should you begin starting out the program?
Well, I think we need to start immediately with the current R1 class. They're the class that has all the changes with the certifying structure. They're actually going to be tested on procedures expected of a radiologist. So it has to be in place for this group, and then hopefully, put in some things to help the classes that aren't going to be tested also get better at it.
Any other comments? So another question kind of spinning off of that is, where should I begin in my program? What should be the first step in initiating these changes?
I think we laid that out with this program.
So they could incorporate the modules basically starting end of spring, early summer. From that standpoint, residents should already be logging their cases in ACGME. If diagnostic residents aren't, that really needs to get going. I think the interventional residents keep track of it a bit more because it's kind of expected to be looked at when we apply for jobs, and doing procedures more often, you're kind of used to tracking them all. Whereas when you're doing procedures more intermittently, you may not be used to the system and then feel less comfortable like going into the system and tracking them. So out here, we kind of teach the incoming residents how to use the ACGME case log as part of orientation. So I think that should be included everywhere, and just making sure residents are keeping track of what they do, just like we do for chest x-rays and MRIs and all that.
Any other comments? Okay, next question. How will the testing of these procedures on the core certifying exam be different than how interventional radiology is currently being examined as parts of these exams? Do you think there'll be a difference in how these procedures are being tested on?
I mean, it all remains to be seen, but Dan DePietro helped me out. I really don't think they're being tested on parathoras and these procedures. They're being tested on the handle of, doing a TACE. I think it's much more complicated procedures and patient management and next steps that they're tested on.
I would agree. These 10 procedures should really be no one should be tested for a TACE on the core, but we are. Because it's just not, you could test that during the interventional board exams later on. They really need to shift more towards testing these 10 procedures, maybe in a little more depth, so that all residents, diagnostic and interventional, really focus on learning them, which is not the case right now. So know exactly how that's going to change, but that's what I would want to be done.
I mean, the ABR has said, like, for DR residents, what DR residents will be tested on when it comes to these more advanced IR procedures is to be able to read the post MRs of a case and to be able to interpret those. So that's the kind of stuff that DR will be tested on.
Makes sense.
When it comes to IR related procedures, if you will.
Any other comments? Okay, last question. Are integrated, kind of similar to this one, are integrated IR residents competent in diagnostic skills as well? Can they accurately read a liver MRI in addition to performing TACE?
You betcha, baby.
In the same realm, I think, you know, when I am 6, 7 years out, if I haven't read a head CT in a while, I would want a reminder of how to do it. And I'd probably have to go back and, you know, remind myself, just like these models and other things are meant to do for those who haven't done a breast biopsy in a while. But that's the type of practice I'm in. If I was doing 50-50, yes, I think I, you know, would be able to maintain some stuff better. So, you know, even in the opposite direction, it is practice dependent. You have to be ready to go out and read diagnostic radiology as a graduating IR. Same a bit in the other direction. Because I'm finding, you know, a lot of my co-residents in IR, you know, are not in 100% IR. I think we're more used to that direction, actually, because a lot of people go out and practice 25, 50, 75% IR and be expected to do diagnostic radiology. A lot of folks are graduating diagnostic radiology residencies and fellowships, not expecting to do these 10 procedures. So it definitely works in both directions, but I think IRs can still read a liver MRI.
Any other comments? Okay, so I think we're going to go ahead and conclude this webinar. I want to thank all of our stellar faculty for your insight and thoughts on this topic. Dr. Pyatt, I'm going to go ahead and turn it over to you.
Thank you, Jen. And we'd like to thank our faculty for this great program tonight and this joint program with the APDR and Dr. Mary Scanlon. Thank you, Mary, and APDR. So please share your feedback with us. We will be sending out a post-webinar survey and a recording later this week. And then we have a next Power Hour topic coming up, which will be workforce issues, tackling long report turnaround times. This will be in February 2024. You can register for that program and other upcoming RLI Power Hour webinars at acr.org/Power Hour. Again, thank you, everybody, not only our faculty, but also our attendees for participating in tonight's program. Good night, everyone.